So I want to say welcome again to the HINF weekly seminar series. We're very excited for today's talk. I want to begin, though, by acknowledging and with respect the Lekwungen, Sanghees, Kaposims peoples on whose territory the university stands, and Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. Many of us are joining from other places, and so I encourage you to think about the land that you are on and your relationship to it and your relationship to the peoples of that land. Okay, so just to let you know, Jonas will be answering your questions at the end of today's session, but that doesn't mean you can't be typing away in our Q&A box while he's talking. He won't be looking at it, and we will take a look at it at the end of the session. Feel free to type it in. One thing to note is because you are typing in your questions and he won't see them to the end, please make sure that if there's anything about the context of what you need for your question, please make sure to add it. So don't say, what's on this slide without telling him what slide you were talking about. Okay. So with that cheerful note, I'm going to go ahead and turn it over to Jonas and let him begin his presentation. Thank you.
All right. Thank you very much, Karen, and thank you very much for everyone that is joining here. Although I cannot see you, I'm sure that you can hear me okay. And it's a pleasure to be here. It's a pleasure to be able to go over this presentation that I'm hoping is going to be informing for all of us. And I'm looking forward to the discussion that we're going to be having at the end of it. Advancing learning health systems. And this is something that's really dear to me and dear to many people that I've worked with in the past. And the question that we're going to be tackling here today is what can machine learning learn from healthcare data? What are the challenges? What are the opportunities that are out there that we can really benefit from, specifically given where we are right now with the advancements in artificial intelligence and machine learning? My name is Jonas Bambi. I have a background in computer science, information technology management, as well as health informatics. I am a faculty within the School of Health Informatics within the Faculty of Health at UVic. Now, before I start and talk about the discussion that we're going to be having today that evolve around the concept of theory, the concept of methodology, the concept of implementation when it comes to implementing complex solution within a complex system, I really would like to acknowledge one of my mentor and one of the person that really has made this possible. It's my previous supervisor for my PhD program, the late Dr. Ken Moselle, that really we had a lot of discussion around the stuff that I'm going to be discussing today. And he confided in me that this was something he's been thinking about for more than 30 years. So whatever I'm going to be talking about here, think of it as somebody somewhere over the last 30 years had been thinking about it. And I'm just continuing, pushing on the baton, and hopefully the group I'm going to be working with or whoever is going to be taking after us, when we're done as well, will continue this same journey. Now, it's a long discussion that we're going to be having. It's going to be touching on a lot of concepts here. So I thought it may be really useful to break it down into parts, right? We'll be talking about part one, which is more around theories that are used within health informatics. We'll be talking about the concept behind QA/QI and how it is or not related to learning health system. We'll be talking about the discussion that is going to be a part of our conversation, what machine learning can learn from healthcare data and the implications of that as far as our systems, our healthcare is concerned. We'll be talking about some use case scenario based on the work that we've done so far. And I'll briefly chat about my program of research. And finally, some rising opportunity just to end the whole discussion with a sense of hope in terms of what is possible, what can be achieved. Now, when we think about health informatics, and this is part one of our discussion, it doesn't just function in isolation. It borrows a lot from different theories. And the ones we're going to be exploring here, it's just a subset of them. I picked on public health as well as health system theory, given the discussion that we're going to be having today. So this ability to draw upon existing theory, whether it's in public health or systems theory or many other theories that are out there, help us to understand how individual, how organizations, how systems interact and influence health. Because we are human beings, we do not live in isolation. We live within, structure, communities, families, and organizations do not live in isolation either. So certain theories that are out there have been borrowed or used by health informatics to be able to build solutions, to be able to promote services, to be able to create services. They also help guide the implementation of effective information technology and intervention. And we're going to be talking about implementation of an information technology approach today. So some of these, as I mentioned, is just a subset. If we think, for example, about public health theory, we can group them into what is known as individual level theory that really focus on individual, as well as interpersonal level theory. Example of individual health level theory will be those that somewhere at individual level, the behavior that we have, the beliefs that we have, how they influence our health. And an example will be like health belief model, which is one of the theory that is out there, or theory of planned behavior, which examine, how, perceived behavior or attitude or norms do have an influence on how we take care of our healthcare or not, right? We also have a trans-theoretical model that is talking about, how different stages, people go through different stages in terms of changing their behavior to be able to adopt to certain things. Interpersonal level theory, on the other hand, goes beyond the individual because we are not just isolated entities. We are part of communities, we are part of families, and these have these social relationships that we're part of have an influence on how we deal with our health as well. And some of the theory that exists out there are social cognitive theory, social support theory, and the list goes on. What about this health system theory that health informatics borrow from? How important is this? This is important as well. It does recognize the fact that healthcare system is really a very complex social technical system. It's not only complex, it's made of interconnected individual, organization, and processes that somehow have to make it work, regardless of the complexity, the diversity of people, of processes that we have out there. It also emphasizes the fact that just changing one system has the ability to have tremendous impact on another side of the system. Or the open system theory that acknowledge the fact that healthcare organizations are open. They interact with the environment. They adapt to internal and external changes. Certain population characteristics may affect it. For example, the COVID-19 that we experience, or the labor market, the shortage of healthcare providers that we're experiencing right now. So all these need to be taken into account because they do have an influence on whatever health informatics does. And this is whether we are implementing behavior change intervention, whether we are implementing decision support system like the one I'm going to be talking about, whether we are improving patient safety, whether we are optimizing healthcare delivery, which is going to be part of our conversation today as we talk about learning health system, or whether we're talking about data analysis and interpreting whatever it is that we're trying to analyze, right? So that's just a way to frame first to make sure that the discussion that we're going to be having today, it's not only about technology, computer science, technical stuff. It's also about a lot of other things that exist out there that we're going to be borrowing from. So that's the end of part one. In part two, I would like to just bring our attention back to the concept of learning health system as well as QAQI, which obviously at the end, the reason we are doing this, the reason we build systems, the reason we build solutions, specifically again focusing on health informatics, is a lot of the time we have this QAQI. That's the plan. We want to improve quality, right? And as we think about this QAQI, you can think of it as a range of activities. These activities are designed to assess and analyze and improve quality of healthcare delivery, and which I think is something commendable because all of us really, at some point, whether we like it or not, will be reliant on these services. An example of these include conducting audit, for example, of patient record to see if there's compliance with clinical guidelines, or to do some root cause analysis to determine some factors that may contribute to medical error. And sometimes this QAQI may be completely outside something that is direct patient care. It could be the analysis of billing, for example, that is not necessarily related to a patient care, but has some connotation to how care is delivered. Okay. And it does rely strongly on behavior systems and interaction, which takes us back to the concept of theories that we're talking about. What about learning health system? We can think of a learning health system as a system where science, informatics, incentive, culture are all aligned to facilitate what we call continuous improvement and innovation in healthcare, right? The aim of it is to seamlessly embed all the best practices that exist out there to deliver the best processes so that the patient not only, and this is really important because we're going to be coming back to it, because the aim is not only about making sure that our process can be as effective as possible, but we want to make sure that our patient or the patient that receive care are actively involved in terms of being active participant instead of being passive receiver. And this is something that we're going to be touching on toward the end because when you think of a learning health system, without patient engagement, is not really, there's a component that is missing there. And there are many examples of these. For example, the ability to be able to use an electronic health system to not only identify a patient at certain risks or certain outcome and be able to take measures ahead of time, or use predictive model to anticipate potential complication and intervene early. Now, the whole idea behind learning health system has been very much represented using multitude of diagrams, right? And this is just one of them. And if you go online, you'll find hundreds of different ones. But all of them tend to focus on these three major capability here. The ability to transform data into knowledge, the ability to use that knowledge to influence practice, better practice, and the ability of those practicing producing new data and that data being used to generate even more knowledge. And the cycle goes on and on and on with the hope to improve on the services. Now, as we think about this, which as you see is measure capability, and it's not an easy thing, going from data to knowledge, knowledge to practice, like data to knowledge, that's where the technology comes in. Part of the machine learning capability that I'm going to be talking about are really touching on that part, data to knowledge. But what about when it goes from knowledge to practice? You may have all the best model that are out there, but if there's no structure that's going to make sure that that knowledge is transformed into practice, then it's useless or practice to new data. So that cycle does rely, and that's really the reason why I talked about those theory, because as we plan about this learning health system, all these theories that I mentioned and many others that are out there need to be taken into account. At the individual level, for example, we need to understand how clinician or patients will react to feedback or to the decision support tools that we build for them. Okay? Or how predicting which intervention are more likely to be adopted as in that knowledge to action cycle. At the interpersonal level, we need to be able to understand how community of practice, peer learning, shared decision, or understand and explain how the knowledge using can be spread using network of influence. We need to be aware of that. Okay. Or at the system theory, when we're thinking about the system that we're dealing with, at least acknowledge the fact that this is a very complex adaptive system where we have new data that are continuously reshaping everything that we're trying to do. It's never static there. It's very, very dynamic, and have knowledge of that is very important. Help identify those and leverage those point of feedback loop. Or when we're thinking about open system theory, right? Understanding that learning healthcare system is within a certain environment that touches on policies, that touches on public health behavior, that touches on labor market. In ways you go. Now, what is the relationship between QAQI and learning health system? One of those is the fact that they happen to share the same goal. And that goal is really both a framework that are designed to be able to improve health, but they may differ in focus, and learning health system LSH being more having a broader, more systematic approach, whereas QAQI is more focused and very specific, targeted improvement. Okay. They tend to be complementary, and a lot of the time, for a company or an organization that is really trying to move toward the LSH, this could be a stepping stone, starting with the QAQR as a stepping stone toward building a more comprehensive LSH. And many of the methods that we already, for some of you guys that are familiar with QAQI, like the Plan, Do, Study, Act, are also applicable to both framework. So we can think of LSH more operating at a different scale, right? From a national health system to a local clinical system, where while QAQI is often implemented at a very microsystem provider level, clinic level. But regardless whether we're thinking about QAQI or LSH, they are all very much data centric. They all are dependent on data. And when we're talking about that, for example, these are just pictures that I picked up. If you think of those, performance indicator at individual level, or you're thinking about performance indicator or dashboard at the team level, or you're thinking about those, analysis of project outcome, or even at national level, when you think about those public health dashboard, these can be considered as QAQI. But what we have here, it's more about counting of this or that. And again, it's good. It doesn't mean it's not good. But I think there's more that we can do than just relying on this counting to be able to tell what is it that need or does not need to be done. And this is more in the realm of QAQI. And if we're thinking to go beyond that, this is really where the second part that we're going to be discussing about takes place. As I mentioned earlier on, we've reached an age where technology has evolved so much that within the healthcare industry, we really need to be thinking of how we can take advantage of it. Hence, this part three will be focused on what machine learning, advancing learning health system. Because as I mentioned, it is very data centric. So, and for us to be able to decipher all that data, we have to have some form of approaches that we use to be able to make sense, go from that, whatever we call data, to knowledge. And that's going to be part of our discussion for this part three. But as we start with this, let's just look at this, what we're referencing here too as the journeys that all patients have as they interact with the service system. So if you look here, we have a person or persons that have, each one has their own clinical status, they have their functional capacity, they have their own behavior profile that could be part of the proximal determinant of health or even distal determinant of health. Like you and I or any other person out there, you're never going to get two that are the same. Each one of us is unique. Each one of us, and when you go to the hospital or you go to receive some care, clinical status, there may be some similarity in terms of clinical status or functional capacity, but behavioral risk and determinant of health, whether distal or proximal, are completely different. But at the same time, this diversity of people have to interact with the diversity of services that are out there. Primary care, acute care, ambulatory care, residential care, you name it, a whole multitude of them. As a result, you not only have complex people, you also have a complex system. The interaction between this group of complex people and complex system create a complex dynamic that we call in, as far as we're concerned here, we are going to be referring to as patterns of service utilization, which is really the interaction between the service system operation and the persons, and I say complex person, that give rise to these patterns of service utilization. That's going to be the point of our discussion today. Because these dynamic determine really what will happen and what is not going to happen. And it also determine how care is provided, but also what will be the outcome of the care that's been provided. And that will be the point of a discussion as we move forward. So just think of this PSU as that interaction, the dynamic that happens when you have a group of people happen to be complex, interacting with a complex system, allowing certain transaction to take place, and sometimes certain transaction not to take place. Now, as we do this, one thing that I wanted to focus on as well is just to zoom a little bit above here. Because as we look at the data, we already have a scenario where we have complex people that are interacting with a complex system. Depending on where we zoom to, because if you think of healthcare data, it does exist at different levels of abstraction, right? I can decide to zoom in all the way to a personal level and start looking at the genome level, at the cellular level. And this is the realm where certain genomic makeup can predispose certain people to certain health problems. This is where the realm of personalized medicine really functions. Or I can zoom out a little bit and think about the bedside care, that is the realm of symptoms and signs and problems. And also the realm where we're talking about diagnosis and uh, procedures and treatment. And as we look at all this, or go a little bit above when we're thinking about cohort and cohort specific kind of protocols, when we're thinking about, for example, adherence to certain protocol, stuff like that, we can see that as far as healthcare is concerned, this is really where the complexity comes in. We can think of it as being at different levels, right? And these are the ones that we refer to as different elements. Level one to be very, very specific to every person, to level two, where we're talking about bedside care, to a level three, where we're talking about certain procedures or treatment or adherence to certain practice or certain problem-specific protocols. All that is just an amount of data that gets generated on a regular basis that for some of these, we figured out how to use, but some others we haven't yet. Now, the good news is every day that pass on, there's a lot of publications that are coming up that's really filling the gap in terms of the models or the algorithm that are being used to consume all this information. And that's very encouraging, right? When you talk about NLP or you're talking about graph networking or you're talking about all different algorithms that are out there, there's a lot that is coming up in terms of dealing with this level. But one thing that was noticed was the fact, especially when we were doing our literature review, we noticed that in the realm, as you go from level six and above, that is now talking about cohort specific adherence to what we call clinical practice guidelines, then we start seeing some lack of publication or some lack of approaches here. And it's not because people are not interested in exploring this, it's simply because of lack of data. Because when you're talking about this level here, you're now zooming out to be at the cohort level. And not only cohort level, these are data that are not only cross-disciplinary, they are cross-programs, they are cross-time, and cover the whole continuum of care. And having access to all that data set has been a challenge. It's changing slowly, and that's part of what we're going to be seeing in terms of the opportunities that are coming up. It's changing slowly, meaning more and more work will be done in this space, but it's been a challenge for researchers, for people that are working in this space to be able to have access to this data. Because what we're trying to do here is to see that we have those that are known as idealized clinical practice guidelines. If this person has this problem, these are the guidelines, these are the stuff that need to be followed. But that doesn't happen necessarily in real world. And hence, if it doesn't happen necessarily in the real world, the question that we want to ask ourselves is what is the delta? What is the difference between what should have happened and what is really happening? And this is the realm of the PSU that we're going to be talking about. Now, we were fortunate enough to be able to have access to this cross-continuum, cross-program, cross-time data set that opened the door for us to start venturing into looking how we can start using this level of data set here, again, to inform learning health system. And that's going to be part of the discussion that we're going to be having going forward. And part of that was, since we're privileged enough to be able to have access to that data, the problem that we're trying to solve was the fact that when we think about clinical service system, they perform a whole range of activities. And these are supposed to be addressing a whole range of problems as well. So as a result of this, what happens is the service system is broken functionally and administratively into service unit, which makes sense because you have a whole variety of problems that need to be dealt with. Now, to be able with such a system, to be able to provide the best possible care for patients, specifically those that have chronic or complex problem, these service units have to be really optimized in terms of how they are interoperating. Okay. And this is done by enabling problem-specific clinical protocols, such as sepsis protocol, but also by enacting what we know as cohort-specific clinical practice guidelines. So there's a guideline for people that have diabetes, guideline for people that have kidney problems, guidelines for people that have this or this other problem. So that's how we deal with them within the healthcare system. However, the challenge that we have is the alignment of the service system operation with these idealized CPG may be hard to measure as far as operations are concerned because for us to be able to do that, we have to be able to identify longitudinal patterns of service utilization in a cross-continuum data set to assess whether this is what should have happened is exactly what is happening. Because again, the complexity of the data set itself, it cross-continuum, it's sparsely distributed across what we know as high dimensional space. So even if we have access to the data, it's not one that can just be readily consumed. You have to have an approach, you have to have a methodology on how you go about that. And I'll give just a quick example here. Let's take an example of a patient that happened to have schizophrenia. So such a patient may need acute care hospitalization. They may need ambulatory care. They may need case management. They may need addiction services. They may need, some access to kidney care because of some medication complication or lifestyle. They may need some cardiovascular help. Now, for such a patient, typically they will be interacting with a bigger and bigger array of services, while their capacity to be able to go across or access all those services may be going down because they're getting sicker. So for such a person, really the quality of what they receive as care dynamically is going to be emerging as an attribute of the service pathway that spread the whole continuum of care, given all the services that are cited here, to be able to do better. And so when we think in the case of such a patient like the one that I just mentioned here, that happen to be having complex problems, so what we consider as evidence-based quality improvement requires that we have tools that we look across the entire continuum of care, which means this tool has to have the ability to discern patterns of service utilization in a very, very large body of cross-continuum healthcare data set. And this is really unlike what we've seen so far because the tendency to tend to be focusing on acute NED and be used as proxy for the entire full system utilization. And it makes sense in the sense that that's where we have the data that is well structured, that is abstracted, ICD-10, DAD, which is the abstract for those that may not be familiar. All this is well structured. These are the ones that we can rely on, that is really nicely structured and all that. But that is not really in reality. It's not a proxy for the entire continuum of care. But the advantage that we have right now, specifically in today's era, is the fact that now tools have been developed, algorithms have been developed, models have been developed to be able to decipher even those information that are not well structured. And as we look at this, the objective that was set as far as this analysis is concerned was based on the fact that one cannot improve processes if you cannot model it, and you cannot model processes and communicate it with those the decision maker if you cannot find or understand or see those models in the data. Hence, the work that we've done, the focus has been on identifying what we call, or supplying, using the data to supply what we call ready for use evidence from a local service system to support more effective service for persons with complex and chronic problems. Now, the focus is, again, on PSU, right? And as we focus on the PSU, the work that I'm going to be presenting here rely on extracting useful information from a clinical information system to optimize the service system structure and function on behalf of patients such as the one that I just mentioned here. And as we do this, as far as this context is concerned, the concept of clinical quality within this context is defined by the degree of separation between what really the patterns or the services or what we call the PSU, the real world PSU, as opposed to what should have happened, meaning the difference between those idealized CPG versus the reality of what happened with this complex patient. That was the objective of the work that I'm going to be explaining here. And this was broken into multiple questions, the research question, one being service integration. How can we go about addressing this challenge of service integration? The other one being about, how are we going to deal with the reality that patient voting with their feet? Not just because you have a service does not mean people will be using it. But can we understand the service that people are using and be able to potentially identify problems with how our services are structured? Now, the last question that we ask ourselves is, now that we're establishing this new way to look at care that is not based on diagnosis, but more of pattern of service access, can we use this new way of thinking about care to apply it to QA/QI? Now, to answer the first question, the first thing that we started with was understanding first that the data that we have, that we're dealing with, is very granular, and it's granular for a good reason. Because as I mentioned, multitude of services are being provided, and those services have to be broken down to address those different problems that exist out there. But when it comes to analysis of something that we're trying to do here, it may be a problem. So the first thing that had to be done was to make sure that the data granularity is addressed first. And an example here being, if you take an organization such as Island Health, Vancouver Coastal Northern Health, if you think of the emergency, for example, you may have a unit like Road Jubilee Emergency, VGH Emergency, Nanaimo Emergency, I don't know, Duncan Emergency. And those are considered as unique or unique services, but in reality, they achieve the same function. So the first thing that we had to do is to address this granularity by building a nomenclature that will make sure that everything that is grouped together is based on the function that they provide. So once that was done, the next thing was to model these, and I'm not going to go into the technical details here because we do not have as much time, but we model this as a graph. And that it's a simple graph in the sense, if you look at what we have here, we have patient A that is accessing this and this and this service. Patient B is accessing the emergency and shelter and addiction. Patient C is accessing this and this and this. And when we look at it and we project it into a service to service relationship, what we start building here is a relationship between services based on how patients are using those services. And technically speaking, is what we call projection into services, this being a bipartite graph. And then with this, the strength of connection that we have for each one of these connectivity here is going to be based on the number of patients that are using simultaneously those services. So the bigger the number, the more connected those services are. Now, by applying what we call community detection, which is one of the algorithms that is out there that is applied to graph, we could be able to group services into groupings that can be integrated together, which means based on these patterns of service access, these services tend to be used together, and these other group of services tend to be used together, hence providing an opportunity for an organization to be able to restructure its services. Answering the first question, service integration. Now, to address this and make sure that we are looking really at what the data is telling us, the same thing was done, but we use a different algorithm. Instead of using graph community detection, we instead use natural language processing. And we notice as well, without going through the technical details here either, we notice that whether using graph analytics or natural language processing, we exactly had the same result, which means those groupings of services that we're looking at was not an artifact of the algorithm used, it was more the reality that the data is showing us. Research question number 2, which was about patient voting with their feet. How can we be able to tell, based on how patients are accessing services, potential problems that we may be having? Now, to address this is a given. We have to have a nomenclature, some form of nomenclature in place to be able to be able to address the issue of granularity. The same thing happened here, like in the first use case scenario, but instead we model the service access as what we call directed graph. The first section that I showed was in directed graph. And if you look at this, it's so easy to understand, right? Let's say this is Jonas here, has access service one, then service two, back to service two, then went to service three, and then from service three, they went back to service two. And this is easily understandable. But when you take a cohort of 10,000 people, 20,000 people, 100,000 people, you start coming up with something similar to this, which absolutely makes no sense. You cannot really see what here. But when you start filtering based on that weight, meaning those that happen to be having more people on there, certain structures start to emerge, certain topography start to emerge. And it becomes interesting when you compare the topography of different cohorts. And an example here, we took three different cohorts, and when we look at the patterns of access in terms of the topology that is shown here, you will notice that this one in the middle here happened to be very dependent on one service, and this service is the one that is connecting them to all the other services. And this can be okay, but when you know and check and see what is this service that tend to be the focal point, when you notice that this is the emergency service, then it's something that needs to be paid attention to, which means those that are responsible for service structuring and stuff like that may want to pay attention. Because what this means, it simply means that for this specific cohort, this is the point of connection for everything, which was not the case for this other cohort that we analyzed. And for these, we have services that are connected to other services without necessarily going through the emergency. And is this a problem? Potentially. Do we have a solution for it? We don't, but the reality is the data is telling us something that those in position of power may want to look at into a little bit more. Hence, when we establish that, parallel service utilization is really something that can be achieved, something that can be extracted from even complex data, the next question that was asked is, can we use this now to be able to, think of improving QA/QI? And we took just a few use case scenarios. Now, I will quickly walk through. The first use case scenario was one that had to do with disparity, which is, we call it, is can we be able to see how different cohorts are accessing services and determine if there's some form of disparity in terms of how these different cohorts are accessing services. Again, this model, similar to what I presented previously, this is just one patient that is accessing service. You can see 1 to 2, 2 back to 2, 2 to 3, and 3 back to 2 again. Now, when you take a whole cohort and ask the question using not only the graph theory here, but also using logistic regression, say, what is the probability for this if you take one cohort versus the other? What is the probability that a patient within this cohort will be accessing, for example, cardiovascular service, or be accessing residential service? Or even better, if they've already accessed cardiovascular services, what are the probability that they will be accessing it again? And what we see here is a range of probability where some of them, the chances are so low that you may want to ask yourself a question, why is this? Why is it that the probability of this cohort to access this service is a lot lower than this other cohort? Now here, to be clear, we're talking about disparity. We're not talking about inequity yet. Because there are services, for example, that may not be needed for a specific cohort versus the other, but it's just a way to start bringing attention to the decision maker and for them to investigate. Because this disparity is likely, there's a possibility it could be an inequity as well. But what the data is showing us, it is showing us the ability across the whole continuum of care to determine and provide that nuanced approach in assessing healthcare equity, using again patterns of service utilization across the entire continuum of care. The other one that we explore was looking at the overdose code and then relying again on their patterns of service access and grouping that specific code because again, what they have in common is the fact that they've all overdosed, that they're part of the overdose cohort. But the question that we asked ourselves was, are they, is it just a monolithic group or are they different groups? And what we noticed when we did community detection on these patient based on their patterns of service access, we noticed that, even if they all considered as overdose, they're completely different groups altogether. One can be considered as being more proactive, having a proactive approach to care, which we call reciprocal group. One can be considered as having more of a disengaged, they only access overdose services and addiction-related services. One is considered as grouped with serious health problems. They usually use medical surgical services, but very low mental health and substance use services. And one is really using more psychiatric services than others. And better yet, as we run survival analysis on it, we notice that two of these groups have 50%, twice as much chances of getting a second overdose than the other two, which means that if you have to come up with a strategy to be able to address this issue, all those groups need to be approached differently. Those that are disengaged, maybe you need a different strategy as opposed to those that are engaged. Again, at the core of it is patterns of service utilization. The other thing that and this is pending publication, that we explore as well, is if we look at these patterns of service utilization, are we able to look at those and even combine those patterns of service utilization with diagnosis to be able to classify patient, meaning look at the patterns of those that have overdose and look at the pattern of those that have not overdose and see the chances of this group of people here, even if they have an overdose, their pattern of service success is likely, it looks like those that have overdosed, meaning have the ability to predict demand if you want, or to classify patients that are likely to be overdosing, maybe giving an organization opportunity to plan better or the ability to be able to tell what is the next likely service that they're going to be using. And this is something that we are doing quite a bit already, right? If you think of all the technology that we have that is predicting what the next word is, and you take that same analogy applied to service access, and you can as well use the same approach. You say, what are the chances, what are the likelihood of the service that's going to be used next? And providing again an opportunity for people that are into the planning of services to be able to plan ahead. Now, this is pending publication. The other one that I mentioned have been published already. So we will see what kind of feedback we get, and we will see how we can push this forward. Hence, when we think about contribution, what I've talked about here is opening new doors. By new doors, it means it gives us an opportunity to allow organization to be able to reorganize some services based on the reality of how patients, specifically those that happen to be having complex issues, those that happen to be vulnerable, are using their services. It gives us an opportunity as well to, at least as a beginning, to potentially identify operational problems. As we saw when we apply to the overdose case, it gives us an opportunity to have targeted strategy when we deal with people that may have the same diagnosis, but their patterns of access is completely different. Or give us an opportunity to have a more nuanced approach in terms of how we measure disparity. Or give us an opportunity to be able to plan better as far as demand estimate is concerned. Now, what are the implications of that as far as learning health system is concerned? The implication, one of them is this is what we have already, which means the planning that we have, the QAQI, are usually based on pre-existing, well-crafted, well-derived data set that have been well abstracted using the DAD, using ICD-10, using NACRS, and the rest that goes on to be able to plan. And this is okay, nothing wrong with it. But what we are advocating for is, can we go beyond that? Can we look at other data sets that we're collecting that go beyond just the diagnosis? Can we look at everything that we are collecting? And as we do that, can we start looking at those patterns and see if those can be considered as new countable, meaning when you're planning for your services at the population level, at the organization level, and say, we have people that have this diagnosis, is what we need to plan for, but also look at their patterns, people that have this pattern, or this pattern of service access, or this pattern of service access, what is it that we need to do with them as well? Hence, with this, what we're doing is to create a new analytical framework that is really allowing us to fully consume all the information that is out there to better inform our learning health system. And that is taking us to part 5, which is, if this is really what we want to achieve, what are the challenges that we need to address? Because what we've done here is just a demonstration that it is possible to extract meaningful patterns, utilization. But if we really want to push it forward so it can be integrated into the learning, what is it that we need to acknowledge? The fact that quality will continue to be a central issue as far as healthcare is concerned. And we also have to make sure that learning is always promoted, always taking place. Hence, the whole promotion of learning health system, which is a really good endeavor. But the question that we want to be asking ourselves is, learning what? And given where we are today, what about learning from everything as an answer? Yeah. And we also have to acknowledge the fact that as we do this learning, it's not really a learning like the one that is done for banking or transportation. It is a complex system that we're dealing with multitude of product environment, with quality that is influenced by a greater level of variability, different patient constellation, different anatomy, different physiology, different preferences, different reality as far as the determinant of health are concerned. So as a result, when we're looking at the oversimplification of the healthcare environment, where we plan based on idealized clinical pathway, it may not necessarily work for complex patients that happen to be having chronic problems, that do not have to rely on simple diagnosis. Now, as we look into this, for us to be able to do and be able to take advantage of, go beyond what has been proposed so far, where the focus tend to be on ED and acute, with pre-existing taxonomy such as ICD-10, DAD, and NACRS. What we're proposing here as a framework is more of a learning from clinical information system across the continuum of care, regardless of whether the data is well structured or not. Use this data to generate dynamic of access to service for complex patients. Use this data to capture what the transactions are telling us in terms of the knowledge that we need to extract from it, regardless of the assumption that we're taking. And use what we call machine learning to understand and find these patterns. And use this pattern to be able to create a new countable. How many people that have this PSU versus how many people that have this PSU? And even incorporate the determinant of health, that's such as social determinant, economic issue, political issues, housing, education, culture, systematic racism, colonization, all that. Now, for us to be able to do that, and it's easy said than done here, is we need some form of target information architecture, which is a part of my program of research. And that target of information architecture is, the goal of it is to say, can we build something that will allow us to consume, when I say everything, it really means everything, have services, population health systems, housing, everything that is out there that we can collect and take it all. And but as we do that, have a systematic approach on how we deal with it. And behind this is this whole concept of content within context. And it's really one of the concepts that is really hard, because these machines, these algorithms are really good at deciphering things, but the context is not there. So how can you build a target that will understand all this content within certain context? And for us to be able to do that, there's a lot of work that needs to be done from a technology perspective for computer scientists and the rest, from theory perspective, going back to what I mentioned before, from healthcare perspective, a lot needs to be taken into account. because the context thing is not an easy thing to explore. So it's part of my program of research, and I'm really looking forward to it. Just started, just framing the problems, applying for grants here and there, and hopefully things will go well in terms of receiving some grant to be able to pursue this endeavor. So part six is what are the opportunities? What are the rising opportunities that we have out there? Because I really wanted to finish this on a high note. So there's currently a CHR team grant that I have applied for. There's a MyTalk grant that I've applied for as well, working in collaboration with Allied Health. And the plan of this, as far as the MyTalks is concerned, the CHR, is for us to go just beyond the predictive model that we have out there and more develop something that is learning-oriented health system architecture that is capable of consuming sectorial administrative data set. And this specifically, we're starting with vulnerable population, thinking of people with opioid overdose issue, children with mental health and substance use. And the goal is to start to identify these patterns of service access, not only within the hospital setting, but also within the community. And when I'm talking about the community, I'm thinking about all the services within the community that these populations are receiving. But at the same time, look at the housing as well. Look at like for MCFD, for example, look at the services that these children are receiving, the care that they are receiving. Okay. So where we not only talking about acute care, primary care, community housing, but we trying to understand all that data within a certain context and see how these patterns that sometimes sit outside a hospital setting, because that has been the focus. Everything I've talked about so far, everything that I've shown you was based on acute care data and hospital care data and all the organizations that are surrounded by already stuff that are related to care. But when we start expanding this and start looking at housing and start looking at the community services and start looking at even primary care, the concept of context need to be taken into account there. But better yet, the plan is to work with not only Allied Health, using a repository that's going to be connecting all this data together, but more importantly, working with people with lived experience. Because one thing the data is going to be telling us, we need to check with people that are going through this and see, does these things that the data is telling us align with your experience? And as I mentioned, there's nothing better than that because we cannot be building systems where we do not have patients involved in the process. Now, a combination between using all these advanced algorithms and engaging with people with lived experience and working with organizations such as Allied Health, I'm hoping will be able to allow us to do something that will really promote what we call learning healthcare system, which is precisely what it's advocating for. Innovation, engaging patient, and pretty much doing everything we can, learning from everything we can to be able to promote the best care for the population that we're looking after. So there is work to be done from the organizations such as Allied Health. There's work to be done from institutions such as UVic. There's also work to be done from the community itself. And there's work to be done as well in terms of engaging people with lived experience. So that's pretty much it. And as I said, this is something that I think is positive, especially given that we have access to the data. We have agreement with these organizations to work with us. We have agreement for person that have experienced these issues to work with us. And I'm hoping it's just the beginning of an interesting journey that we're going to be looking forward to. And I thank you for your attention.